Combat Casualty Assessment. Care under fire. Return fire to gain fire superiority. Direct the casualty to return fire, move to cover, and apply self-aid if possible. Direct security team to provide security for the casualty. Move to casualty once security team is in place and signaled for medic to move forward. For major life-threatening extremity hemorrhage, apply hasty tourniquets high on the limb over the uniform to control obvious extremity hemorrhage, and move the casualty to cover. Tactical field care phase. If tactical situation permits, take body substance isolation precautions. If not completed previously, assess responsiveness and chief complaint. Determine if the casualty is unresponsive or responsive by shaking the casualty gently with your hand and ask the casualty if he or she is okay. If the casualty is unresponsive, assess for the presence of carotid pulse and respirations. If absent, respond in accordance with the tactical environment. Perform a blood sweep of the neck, axillary, inguinal, and extremity areas. If needed, apply the following interventions. Rapidly apply hemostatic agent, holding pressure for 3 minutes, to the neck, axillary, and/or inguinal wounds discovered. Assess the effectiveness of previously placed tourniquets. Check the wound for further bleeding and ensure the tourniquet is tight. Rapidly apply deliberate tourniquets to any new wounds discovered on extremities. Airway. Open by performing the head tilt, chin lift, and assessing the airway. Look, listen, and feel. Insert the appropriate adjunct as indicated, either an NPA or a surgical crike. Position the casualty to maintain an open airway. Breathing. If wound is present, expose wound and assess torso. Remove casualty's equipment or IBA if injuries are present. Manage penetrating torso wounds if present. Use an occlusive dressing. Check for an exit wound. And if the casualty shows signs of respiratory distress, use an NCD. Place casualty in sitting position or injured side down in the recovery position. Assess breathing for equal rise and fall of the chest and spontaneous respiratory effort. Check for adequate spontaneous respirations. Inspect and palpate for decap, deformities, contusions, abrasions, punctures or penetrations, BLS, burns, lacerations, and swelling, and TIC, tenderness, instability, and crepitus, in chest, shoulder girdle, sternum, the anterior and posterior rib cage, and the axilla. Monitor the casualty's respiratory effort. If the patient is experiencing progressive respiratory distress, and has torso trauma, perform a needle chest decompression. Reassess the casualty's respiratory effort. If other injuries permit, position casualty to facilitate respiratory effort. Circulation. Treat significant non-pulsatile hemorrhaging with packaging as necessary and pressure bandage. For wounds treated with a hasty tourniquet during care under fire, expose injury and assess for continued tourniquet need. Complete the following sequence to convert the hasty tourniquet to a deliberate tourniquet. Reassess packing of junctional wounds, such as neck, axillary, or inguinal if present. Need for vascular access. Check radial pulses. If absent, check for carotid pulse. If the casualty has significant injuries but presents radial pulses and has normal mental status, use a saline lock. If the casualty has significant injuries, absent radial pulses, and an altered mental status, use a direct IV cannulation and fluid resuscitation. An IO should be placed after a second IV attempt is unsuccessful or not possible if the casualty is requiring fluid resuscitation. Reassess the casualty's mental status and radial pulse. If there is no radial pulse and AMS, administer a second 500 ml Hextend wide open. Wrap any junctional wounds, such as neck, axillary, or inguinal wounds, if present. Notify the tactical leader for casualty evacuations, lines 3, 4, 5 of the 9-line medevac. Reassess prior interventions, HABC. Check for specific drug allergies before administration and administer appropriate pain management. Ketamine slow IV or IO push. Fentanyl by mouth, PO. Mobic by mouth. Morphine sulfate, IV or IO. Detailed physical exam. Head assessment. Inspect and palpate for DCAP, BLS, and tic. Inspect eyes for pearl, pupils equal, round, reactive to light. Inspect mouth, nose, and ears. Manage any injuries appropriately. Neck assessment. Inspect and palpate for DCAP, BLS. Palpate cervical spine for tic. Check position of the trachea. Check the jugular veins. Manage any injuries appropriately. Chest assessment. Inspect and palpate for DCAP, BLS, and tic in chest, shoulder girdle, sternum, the anterior and posterior rib cage, and axilla. Auscultate bilaterally for presence or absence of lung sounds. Manage any injuries appropriately. Abdomen and pelvis assessment. Inspect and palpate for DCAP, BLS, and TRD, tenderness, rigidity, and distension. Assess the pelvis for tic. Inspect the genitalia and perineum. Manage any injuries appropriately. Lower extremities assessment. Inspect for DCAP, BLS. Palpate for TIC or tic. Assess motor, sensory, and circulatory function. Consider splinting the extremity. Consider alternate hemorrhage control measures and tourniquet conversion if the evacuation time is delayed in excess of 2 hours. Manage any injuries appropriately. Upper extremities assessment. Inspect for DCAP BLS. Palpate for tic. Assess motor, sensory, and circulatory function. Consider splinting extremity if required. Consider alternate hemorrhage control measures and tourniquet conversion if the evacuation time is delayed in excess of 2 hours. Manage any injuries appropriately. Posterior thorax, lumbar, and buttocks assessment. Inspect for DCAP BLS. Palpate for tic along spine. Check for BUDS, blood, urine, defecation, and secretion. Manage any injuries appropriately. Prepare for CAS evac. Prepare the casualty to prevent hypothermia and place them on an evacuation device. Reassess the casualty. Elicit the ample history and baseline vital signs. Complete the Tactical Combat Casualty Care Card. If the evacuation to higher echelon surgical care is delayed up to 3 hours, administer the appropriate antibiotic for penetrating trauma. If the casualty is able to swallow, administer moxifloxacin PO. Cefatin for slow push IV or IO. Ertapenem IV or IM. Secure the patient to the evacuation device and prepare for transport. Continue reassuring and reassessing the casualty until medevac arrives.